Think we're going to get started. So I'm Heidi Dees. I'm the co-program director of MCT2D. So I'm going to kick us off here. So as per the usual, we have a jam-packed evening planned. I'm going to give some collaborative updates. Then we have very exciting two experts here from U of M, Dr. Papasuri and Dr. Hun, who's sitting here, to provide the endocrinology and nephrology updates. We're going to get into some breakout sessions and discuss some of the quality work we've been doing. And then finally, we'll be wrapping up with some pretty cool previews of what's to come in the next year. So I'm very excited to share that with you. So here's a short list of the many accomplishments we had this past year. So your POs are now getting quarterly reports from our dashboard. We have more patients in our dashboard. So it includes BCN patients now. In November, we launched the patient empowerment tool, so we're going to talk about that in a little bit. And then finally, we've all been getting our feet wet in some quality work. So we'll be spending some time, as I mentioned, talking about that in our breakout groups. If you haven't had a chance already, get your phones out and take a picture of this QR code. It takes you to our year in review. I'm biased, but I'm quite proud of all of the work we all have done. So some pretty amazing summaries are in there, and it's all because of all your hard work. So thank you. This is one of the things that I think is amazing. Our resources are being used worldwide. So we are global. So over 133 countries have had people download our resources. We remain committed to always providing updates on our three pillars. You guys have told us that's what you want. So we're going to kick it off here with what is often listed as one of your favorite parts of these meetings, the medication updates. So some coverage updates. This one is in regards to Medicare Advantage. We now have Aetna Medicare Advantage and Blue Cross Blue Shield BCN now having Mounjaro as a preferred GLP-GIP. I would like to make the note, in both cases, we want to be sure to put the ICD-10 code on the prescription. The Aetna does require prior auth, but I will say I've gotten now into the habit on all the prescriptions for GLPs for patients for type 2 diabetes that I'm writing for. I just automatically include the diagnosis code now, because if the payer might have a look-back PA, it might mean less work for us all. Converse to that, we've seen some GLPs kind of falling out of coverage. So Victoza now on 5 of these plans here, Aetna, Blue Cross Blue Shield, BCN, HAP, United, and WellCare are no longer covering Victoza. It might not be a shock, but next month the patent runs out for Victoza. So I imagine the payer rebates will be stopping, so that could be why we're seeing this. So big news for semaglutide last month. We saw label expansion to include now CV risk reduction for semaglutide as Wegovy, and a big announcement from CMS on anti-obesity medications. And so these results reflected the SELECT trial, which I'm going to talk about in just a second, which demonstrated a 20% risk reduction in CV death, non-fatal MI, and non-fatal stroke in those patients taking semaglutide with overweight and obesity who had a prior CV event or had symptomatic PAD. So we anticipate that Part D plans and Medicare Advantage plans will limit their coverage of this particular drug, again, semaglutide as Wegovy, to people with prior MIs, stroke, symptomatic PAD, amputation, revascularization. But again, we don't know when this is coming. So if we take how everything came down with CGMs last year with Medicare, when they expanded coverage, that came out in April. We didn't see plans change until January of this year. So we will let you know as soon as we hear something. So to give you an idea of who these patients were in the SELECT trial, it was over 17,000 patients in over 804 clinical sites in 41 countries. The average age of the participants were 61 years old with an average BMI of 33. None of them had diabetes. So they did, though, have 70% who had a prior MI, 20% had a prior stroke, 4% had symptomatic PAD. That left about 8% left over that had a combination of those. So just to give you an idea, this is going to be the patient population that likely is going to be isolated when the payers decide to expand their coverage. So speaking of, I forgot to mention, in the SELECT trial, 87% of them were on statins. So that was my segue to this slide. Just as a reminder, HEDIS has statin therapy in patients with diabetes ages 40 to 75 as a HEDIS measure. So we just wanted to remind you that information's in your dashboard. So you can see if a patient's on a statin or not, and hopefully that'll support you meeting your measures. I was really, really hoping to have some good news to deliver on this front, but unfortunately, it seems to be the bane of my existence, and I'm sure it's the bane of yours. So on a flip side, the positive note, we are getting lots of good feedback on our GLP switching tool, and I have had lots of conversations on how hopefully this tool is helping not only give an idea of some approximate dosing, but most importantly, to ensure tolerance of our patients and decrease chances of poor side effects. Because I myself had a patient who was impacted by a provider, we'll say, who didn't properly switch the patient and went from Trulicity 4.5 to Mounjaro 15, and patient was in the ER for nausea and vomiting. Not surprising. So I have worked in kind of a routine that I have. So I tell my patients when if they're on a weekly GLP, call your pharmacy that day and order that refill. It gives us a little time. If the pharmacy calls you and says, hey, you know what, this drug's on back order, I don't have it, I tell my patients ahead of time, find yourself a little radius that you're willing to travel to. Once I've identified that radius, start calling pharmacies. If you find a pharmacy that has your drug, send me a portal message. I will be happy to send the prescription to wherever you find it. But the last point to this is, do not spend 2, 3, 4 weeks trying to play GLP detective. Let me know after a week if you can't find it, because it might mean I need to switch up to something else, maybe another GLP, maybe oral Rybelsus, maybe an SGLT2. But it's important to emphasize to patients, let's not wait till the next time you see me. Let's get you on something to maintain that glycemic control. So as much as GLPs are affecting us, it's really affecting our patients and impacting their behavior. I don't know if any of you have seen some of the editorials out there, but there's online forums of patients selling, exchanging their diabetes supplies, their diabetes medications. As a pharmacist, the exchanging or selling of medications makes me cringe. But at the same time, I get it. These patients can't get their meds. They're desperate. So I'd like to introduce Kelly and Doug. The region they're going to be speaking live at is Gaylord, but Noah from our team put this amazing video together just to share their story. And so they're going to be talking about their challenges with access and affording Mounjaro.
Been together since 1978.
And we've been married 43 years. So it's a lifetime.
You had a funny story for me about a certain drug deal going on her front porch that involved a sandwich. Can you share that one, Kelly?
Yeah, I'll share that one. Yeah. When Doug got COVID, he worked at Otsego County EMS. He was an EMT, and it happened. And we're sure it happened out on a call. While 7 other people that worked with him got COVID. My Doug was the worst. Then there was another Doug that was not quite as bad, and then it went down from there. Well, the other Doug, bless his heart, had been on Trulicity, but they had taken him off the medication, but he had all this extra Trulicity. He says to my Doug, which I know we're not supposed to share a prescription. I understand that. But he couldn't get it, and he needed it. So he comes to our house, and they're out on the driveway exchanging this little brown bag that looked like a sandwich, your sandwich bags. They're exchanging that in the driveway at my house. I said, this is like a drug deal going down. Money was exchanged, just drugs. his drug. It was the way we could get it because he needed the medication.
Next Monday will be 4 years from when I left my job at halfway through my shift because things just weren't right. Well, I was at home for 10 days because I'm a medical professional. I'm going to be okay, blah, 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 until I couldn't breathe anymore. But I also think that is the part of what helped me get through a lot of it, is I'm stubborn. I don't like to be told what to do. And I've got a lot of people that think I've only got 6 lives left. They didn't know me when I was younger.
No doubt with Doug, he just fell into the perfect storm. He was in the forefront of all of this when it first happened, before we even knew what to really call it. And then before we knew it, he was one of the first to fall with the COVID and fall hard. And Kelly and I spent many evenings on the phone together. One night I remember talking to her late in my office, and she was in her car in the church parking lot down the street. And it's just, we were just talking and praying that we'd get Doug through this somehow.
When Doug couldn't go back to work, my employer had us on a high deductible plan. So when Monjero is $1,000, it was difficult. And I know now that I'm on Medicare, what surprised me is you can get a coupon if you're on commercial insurance to where you can pay as low as $25 a month for Monjero. I was on that because I was employed. Now that I'm on Medicare, that is not included. But to me, our seniors and retirees are the ones that would need that assistance the most. It needs to be addressed for these people because they're going to skip their medications.
One thing about these two is they're very much a team. They help each other bounce well across each other. Good. And they've got the perseverance like no other that I've ever seen. There's a lot of couples. There's a lot of husband and wife couples that I have that have diabetes, and they work this together as a family. But these two are really, really unique. Even though their situations are different, their medicines are a little bit different, they work together really well that way. And that's made my job a lot easier too.
Well, thank you.
Yeah.
All right. How many of you have had similar stories to that? So, yeah. So much work. We'll keep working, right? We'll keep advocating. So switching gears in terms of CGMs, I'll pause because we share and we hear your disappointment that occurred when Blue Cross Blue Shield of Michigan changed their CGM coverage. We're a month into this coverage that's listed on your right. So now all patients are required to be on insulin or have had 1 or more level 2 or level 3 episodes of hypoglycemia, or have postprandial hyperglycemia in pregnancy in order to get a CGM. We are 1 month away from patients who previously had coverage through Blue Cross Blue Shield of Michigan who were not on insulin, losing that coverage. So as of May 1st, they will no longer have that coverage. So we want to highlight a potential opportunity and hopefully a little bit of hope here. If you have a patient with Blue Cross Blue Shield of Michigan, underlining that, PPO, underline that, commercial, they are eligible for the Patient Empowerment Toolkit. So again, that contains 6 Libre 3 sensors, a electronic blood pressure monitor, and a wireless scale. And this is all at no cost to the patient. So we've just wanted to give you some stats. We rolled this out November 17th, 2023. We've had 51 prescriptions sent in to our partner, J&B Medical, on this. But only 35% of them have actually shipped. And so you might be wondering why. Large percentage, 23, patients do not have Blue Cross Blue Shield of Michigan. They have out-of-state Blue Cross. Again, not eligible, unfortunately. Or they have Medicare Advantage. also, unfortunately, not eligible. So again, commercial Blue Cross Blue Shield of Michigan PPO are the ones that are eligible. We had 10 that are still working on trying to figure out those benefits, and then also trying to get a hold of the patient. And so some things that I'm going to be echoing here, if you can help us out, so your patients, if they truly are eligible to get this, they need to answer the phone when J&B calls. Now, it might be blocked. I don't always answer my blocked calls. So if you can tell them within the next 24, 48 hours, if you could just answer your phone, if there's a human voice at the end, proceed to talk. And they also should be told to be ready to share their email. J&B is trying to get everything up for you as the prescribers. So they're getting them set up with LibreView. Some patients aren't sure, who are you? Why are you asking for that? J&B is not going to keep their email. They just need it to get that process of setting the patient up with LibreView. So if you can tell your patients about that, this would be great. Have any of you sent an order in yet? No, me. I have one, so very happy patient. So good. Well, hopefully we can get some more patients on this. We are, though, hearing some frustration, and we always want your feedback, so keep that coming. But we wanted to give you feedback on your feedback. First of all, J&B and Blue Cross Blue Shields have been great partners in this. J&B especially is willing to hear whatever the complaint is and actively work on a solution. So these are some of the things we've identified. And here you'll have these slides, or take a picture of this slide. This is the phone number you want to have, that if you have a patient or you have a question about anything related to the patient empowerment tool, call this number. Even if you have a local person that you typically deal with, call this number. It's only been called 5 times since November. The people on the end of this phone line know exactly what to do. They know all about the patient empowerment tool. So this is how we can get some action. Next is processing times. Yes. Okay. So I just to kind of summarize, in case you didn't hear, a patient was in and out of the hospital with hypoglycemia and hyperglycemia, and J&B couldn't process the CGM because of what again? Oh.
And they would not qualify for that month.
Okay. If you wouldn't mind sending us an email. Okay, well, I guess the one thing I will say is in regards to this patient empowerment toolkit, I believe there's.
She did have a amplification, but we did try to utilize every resource.
Okay, well, thank you for doing that. I'm sorry to hear about your patient. Well, I'll next time I'm talking to J&B, I'll just make sure the bit about the CGM in hospital, I don't actually think it applies to the patient empowerment tool, separate benefit. Already mentioned in terms of making sure patients know to answer their phone. And then talking about email. The other thing is some patients are actually requiring that all the paperwork be sent in the mail. And as we know, snail mail, unfortunately, is snail mail, so that can delay things. We do know when everything goes as planned, patients are getting their toolkits in 2 days. So again, it works. We just got to have everything in line to help it work. The other big thing we've heard from you all is the frustration with looking up whether a patient has PDCM, so provider delivered care management coverage. J&B, as soon as they heard this, said, you know what, we can help with that. So if you have a patient You know they have Blue Cross Blue Shield of Michigan. You know they have PPO. It's commercial. Send it on in. Don't worry about the PDCM. Once they get that prescription, they will go ahead and verify the PDCM eligibility. So that kind of barrier has now been taken away. So yeah, I think that's about it on that. Finally, I think it's hopefully still in the back. It was supposed to be in your, is it in the back? Oh, we changed things since Tuesday. So now it's in your folders and at the back. Our new patient empowerment tool workflow. So just to kind of help you out, we as a team worked through this. So just to have your practices take a look at this and how they can better incorporate that into practice. You probably heard Dexcom's coming out with an over-the-counter CGM. We don't know too much about it. We know there's not going to be any alarms. Patients have to be 18 or older. I think as MCT2D, we have some concerns whether this will lead payers to saying, oh, patients on insulin, they can just use this one and pay out of pocket. In the conversations I've had with payers, they have said, you know, we do cover things that are over the counter. So more to come. Know that MCT2D will continue to be strong advocates of broader coverage for CGMs. Speaking of advocacy, Dr. Lauren Oshman back there wrote a letter to the ADA, just trying to call upon perhaps a review of how guidelines are looked at, given the fact that ADA uses grade A level evidence and that the payers look directly to this. And so there is evidence of lesser quality, perhaps grade B or C, and looking ahead as to what we're dealing with right now with, you know, Blue Cross. They looked at the ADA guidelines. It says indicated for insulin. That's where we are. So we're going to continue to work. I myself met with the Michigan Pharmacists Association, kind of switching gears back to GLPs. Asking for some sort of call to action to the manufacturers of GLPs, because I feel like this has been going on long enough and we need to have more than just sorry and we're building plants. Been hearing that for several years now. So Michigan Pharmacists Association is going to be talking to other Pharmacists Association. We also, the American Pharmacists Association is right in DC. So they're going to also talk to them about kind of what sort of advocacy we might be able to do. Switching more gears over to low carb, another new resource that is available on that back table. And so this is meant a cool poster to hang up in your clinic rooms, has QR codes from a lot of the resources that you know about. So when patients waiting to see you, they can take a look at some of these great resources that our team has developed. I wanted to share with you, Gluco is a EMR software that we have at U of M. It's very expensive, but they have a free app for patients. And one of the cool features I learned about, and I've actually been telling my patients about, they can download the Gluco app for free. They can click on food, and that's that top right screen. And there's a little microphone. When they click on that little microphone, that bottom screen lights up with that microphone. It's live, and they say, I had an egg and a piece of toast for breakfast. It will calculate the carbs for them. So I've been using this with my patients who never want to, get out their phone and look at Google and try to Google things, but they're willing to talk to their phone. So I think it's worth a try to make sure patients gain some awareness of carb counts. Okay, so moving on to the end of this, we just wanted to give you an update of how you're doing. So one of the things I first want to point out is this top line, which is metformin. If you remember back in the fall, it was pretty sad. It was pretty low, and we were wondering, we know our patients are on metformin. So it was our team that identified a bit of a flaw in how the data was coming to us from our vendor. So we are indeed, our patients are on metformin, so that's great news. The other thing is, just to point out, this graph begins January of 2023. So if you recall in years past, there was quite a dramatic upswing when the collaborative first started. And if you really look close at this, SGLT2s is the green line. So we are still seeing an improvement. Just from the fall, it's increased by 0.5%. It's up 2% since January of 2023. So we are moving in the right direction. However, GLPs, which is the orange line, there's a slight decrease. Probably not that surprising with what we're all going through with the shortage. So about a tenth of a percent point decrease, but overall 2% decrease since January of 2023. But we think we know why. So this graph shows the patients from the dashboard, about 1,900, who have A1Cs over 9. And not surprising, they're on many medications, but it's that first column that I want to highlight. There is about 18%, so 300 patients with A1Cs over 9, on one medication. That's a problem. So therapeutic inertia is out there. We need to continue to work on this and get these patients to goal. So we should be talking about changes and getting that A1C down at every visit. And then finally, just SGLTs represented on the left and GLP-1s on the right. We know from evidence these drugs work, but just to show from our data, we are seeing improvements for A1C. So we've seen about a 0.5% decrease in both. So we're just happy that things are going in the right direction. And I think that's it. So at this time, I'm very excited to introduce Dr. Hung, who's going to give us a nephrology update.
Hey everybody, Mike Hung. I'm a nephrologist from University of Michigan, and I'm helping to oversee the kidney component of MCT2D. And keeping with the theme of always trying to provide up-to-date information, today we thought we'd talk a little bit about advances in CKD management and maybe how we're using the medicines or emerging uses for the medicines that we've gotten hopefully quite familiar with at this point. So these are my disclosures, nothing relevant to this talk. And I'm going to talk first about SGLT2 inhibitors in patients with chronic kidney disease without diabetes. And many of you already know that the indications have expanded, so I'm going to go over that pretty quickly. Then talked about the non-selective mineralocorticoid receptor antagonist that has become available, that's also looking to be a very important tool potential important tool for diabetic kidney disease. And then just a little bit of information coming out on the GLP-1s. So first of all, I think it's a pretty exciting time to be a nephrologist. Hopefully my nephrology colleagues up here at the front kind of agree with me. This is a picture from one of our recent faculty meetings at Michigan. You know, for many years, we had ACEs and ARBs, right? That was our mantra, ACE, ARB for our patients, and those were our main tools. And they're still important tools for us, of course. But it's really been exciting the last 5 years to now have more and more tools coming out that really have significant benefits in our patients and really have the chance to change the epidemiology of kidney failure in the US. First in diabetes, which is what this collaborative obviously is focused on, but as we'll see also in patients without diabetes now we're seeing. So chronic kidney disease, very prevalent issue, more than 1 in 7 patients in the US. You guys are all quite familiar with this. A little bit of a good news, bad news story. We have seen some good news in that there has been some decrease in chronic kidney disease attributed to patients with diabetes over the last couple of decades. But it's, and we think a lot of this has been from improved focus on glycemic control and again, our ACEs and ARBs. The bad news is it remains the most common cause of kidney failure in the US, and as recently as 2021, 60,000 patients in the US starting on dialysis, incident patients had diabetes as their primary cause. Back to some good news, we have seen a proliferation of treatment options, and not just for glycemic control, but really starting to demonstrate the ability to change actual outcomes. So I'm not going over the diabetes-related data, which I think we're all very familiar with and have adopted now. But this is, I just wanted to present a couple of studies that have really focused or expanded to non-diabetes. So probably the first big one that came out was the DAPA CKD study. So over 4,300 patients. It was dapagliflozin versus placebo in patients with chronic kidney disease with or without diabetes. So as opposed to previously just patients with diabetes in the studies. These are high-risk patients, so they have impaired GFR plus pretty significant albuminuria, which is a very significant marker, as you know, for kidney disease progression. And these patients were already on mostly on standard therapies with statins and ACE-ARB. The primary outcome here was a kidney outcome, looking at a 50% decrease in GFR, development of actual kidney failure, meaning dialysis or a transplant, and then death from a renal or cardiovascular cause. And you can see that there was a very significant reduction in that outcome, that composite outcome with the dapagliflozin. And the really exciting part was if you look at the subgroups and you divided it into the patients with diabetes versus without, you can see that, I don't know if this is a marker, yep, with the non-diabetes group, there was a still significant reduction, actually a 50% reduction in risk over time. So that was pretty exciting for us that take care of patients with chronic kidney disease. And pretty similar findings in the EMPA kidney, which is quite similar, slightly larger, 6,600 patients, EMPA versus placebo. This did lower the GFR entry criteria to 20, okay? And once again, high-risk patients, if they had a higher GFR, they had to have some albuminuria as well. Once again, focused on a composite renal outcome, and once again, showing significant reduction in the overall outcomes with empagliflozin compared to placebo. What this study, I think, added, again, more studies, more patients, rather, another 3,500 patients without diabetes who had chronic kidney disease. And again, you can see that within this subgroup, there was benefit there. As I kind of alluded to, this included patients whose GFR was down to 20, okay? And when you looked at that subgroup of eGFR in that 20 to 30 range starting out, you still saw, once again, a significant benefit even in those patients. And then the third thing that's a little bit controversial is they had patients who did not have albuminuria, and it wasn't as many patients, and there weren't as many events. For those of you that might not be able to see, it's 42 events out of, with 660 patients in each of the groups, okay? So you might look at this and say, well, there was no difference in those patients. Maybe there's no benefit there. People have done some analysis and suggested that the slope of GFR decline was still a little bit better in the empagliflozin group. And so possibly the reason that there's not a statistically significant difference is because, you know, this study was about, I think it was a 3-year long follow-up on average. In theory, if you followed these patients out long enough, those curves, the survival curves, would eventually separate, and you might be able to see that, okay? But the fact that these patients don't have significant albuminuria, they're in that lower risk group, you're just not going to see as many events over the study follow-up. So I don't take this as saying that they won't benefit from this, but from at least from a renal perspective, but you can't conclude that for sure here. Certainly in the higher risk groups, though, pretty convincing benefits. So kind of, you know, where are we at? Nephrologists kind of want to put this all in the water, right? We just want to get this in the water system. SGLT2s for everybody. I think, again, anybody with diabetes, you can make the argument, of course, as a diabetes medicine. Certainly patients with cardiovascular risk. We know about the heart failure indications and the diabetic CKD. The major change now is the non-diabetic CKD with GFRs down to 20 and with albuminuria and possibly without albuminuria as well, but that wasn't clearly shown as I just went over. So the FDA labeling has actually caught up with this new data. So both dapagliflozin and empagliflozin now have labeling to in patients without diabetes. So for DAPA, it's a CKD indication, adults with chronic kidney disease at risk of progression. And for EMPA, reduce the risk of sustained decline in GFR. So basically that composite outcome in adults with chronic kidney disease at risk of progression. So without diabetes, no, you don't have to have the diabetes. This is just another call out to the resources that we have available on MCT2D, and we have a table over there with some of the newer handouts. I use these all the time in clinic myself, and I think it's great to have these resources. And of course, we're always interested in feedback from all of you of potential other resources that you think would be helpful for your patients or in your clinics. I'm going to talk next about the mineralocorticoid receptor antagonist for diabetic kidney disease. By way of background, I think we've known for a long time that aldosterone has a role in promoting inflammation and tissue damage in diabetic kidney disease, in diabetes in general, and in other conditions. Spironolactone, for example, has been demonstrated to be beneficial in patients with heart failure and after MI to help with remodeling and fibrosis. Now there's been emerging evidence of that role in the kidney as well, and in some small studies, some of the older MRAs like spironolactone and eplerenone have been shown to reduce albuminurias in some small studies. A newer drug came along, finerenone. It's a non-steroidal MRA that has a little bit better selectivity, receptor selectivity, and large trials comparing finerenone versus placebo in patients with diabetes and in chronic kidney disease with albuminuria, or at risk for chronic kidney disease with worsening chronic kidney disease with significant albuminuria. Once again, like the SGLT2 inhibitor trials, already on standard therapies, including ACE or ARBs. But these trials did not include, they were done at the same time as the studies being done with SGLT2. So most of the patients were not on SGLT2s at the time. Again, looking at a primary outcome of kidney outcomes, and basically showed a significant reduction in hard kidney-related outcomes with this medicine. Also, these medicines, as we're familiar with, can increase potassium and lead to hyperkalemia. So I think it's important to point out that these patients, in order to qualify for the study, had to have a potassium less than or equal to 4.8 to begin with. And they did see some increased hyperkalemia, increased potassium overall in the population, and increased hyperkalemia, although the degree of hyperkalemia requiring discontinuation was relatively small, 2.3% versus 0.9%. A follow-up study focusing more on cardiovascular outcomes showed significant cardiovascular benefit as well with these medicines. And when they did look at the secondary outcomes, they did also see a trend towards decrease in the kidney outcomes. So again, part of the theme of exciting time to be a nephrologist, we just getting over the euphoria of having SGLT2 inhibitors, and then we have another drug that comes along that seems to be beneficial in reducing these hard kidney outcomes. And that's what this is showing here, basically, kidney failure, a sustained decrease in GFR, or a sustained drop in the Figaro study. So this also has been quickly adopted into guidelines. Finerenone has been available for the last almost 3 years now, is approved in July of 2021, and both the ADA guidelines as well as the KDIGO, which is the Kidney Disease Improving Global Outcomes, kidney-related guidelines, have adopted the non-steroidal MRA into the algorithm, basically, for managing patients with chronic kidney disease, diabetic chronic kidney disease. Just a quick comparison of the different MRAs. These are the three available. The spironolactone and eplerenone have been around for a while, and then finerenone is the new kid on the block. With the non-steroidal and higher receptor selectivity, you tend to get a little bit less hyperkalemia, although again, there still is the risk of hyperkalemia. And you get in theory, no anti-androgenic, which is a really important side effect that we sometimes see with higher doses of some of the older MRAs. So that's a significant benefit. And of course, you have the clinical trials that were done actually with finerenone to demonstrate the benefit. one thing you lose actually is that you don't have as much blood pressure effect. So if you have a patient who already has very good blood pressure control or even borderline low blood pressure control, finerenone actually might be a good agent. Conversely, if you have a patient with suboptimally controlled blood pressure who you're still trying to get to goal, who has CKD and some diabetic kidney disease and some albuminuria, you might actually opt for a spironolactone instead to get a little bit of extra blood pressure control, kind of a 2-for-1 situation. I do think that there probably is some benefit from a nephrology perspective with some of the older MRAs. Again, there are some smaller studies that suggest that, but it's technically the 1A evidence is for finerenone. Still several unanswered questions with MRAs. For example, non-diabetic CKD, there are studies ongoing looking at that now, and we're kind of optimistic that we will see the same benefit whether patients have diabetes or not. And then I kind of alluded to where does this fit in relative to the SGLT2 inhibitors. I believe that hopefully they will be synergistic, that you can use them together, and I have been doing that. But there actually is a study comparing them head to head as well as together. And so we'll hopefully learn a little bit more information about that and maybe how to prescribe those together. So just last thing is a quick update on GLP-1s in diabetic kidney disease. An exciting thing that's come around is that the FLOW trial, which was a randomized controlled trial of semaglutide in patients with type 2 diabetes and chronic kidney disease, looking at primarily cardiovascular outcomes, looking at primarily kidney outcomes with a 50% decrease in GFR, ESKD, and renal or cardiovascular death. This study has been ongoing, and in the fall it was announced that this study was stopped prematurely by the Data Safety Monitoring Board because the study met efficacy criteria. Okay, so I have not seen any more data or any data specifically beyond that, other than that news release, but clearly that implies that they showed that the medicines have benefit in this. So we already, I think in this group, fans of the GLP-1s for the benefits, for metabolic benefits, for the cardiovascular benefits, and hopefully next time we meet, we'll have the actual data presented from this that's showing also renal specific outcomes. And so in previous meetings, we've talked about things like, should I do an SGLT2, knowing that that's the big renal benefit in a patient who has also really high metabolic, or should I do GLP first, or things like that. This might change actually how we think about that if we actually do see the renal benefits from GLPs as well. So just quickly to summarize, the SGLT2 inhibitors have now been shown to be beneficial, not just in patients with diabetes, but also non-diabetic chronic kidney disease, and the indications have followed for that. Non-steroidal MRAs, with which there's only one in that class right now, finerenone, has also been demonstrated to have both cardiovascular and renal outcome benefit in the same population, in patients with diabetes and chronic kidney disease. And we may be getting even more good news from a nephrology perspective in terms of the GLP-1s. I think we have time for a couple of questions, if anybody has any questions.
I just have one question.
Yeah.
So my question is, SGLT2 inhibitors are quote unquote not indicated if somebody has been on recent immunosuppressive therapy. What about patients with nephrotic syndrome, membranous, and things like that? Because once they're done with rituximab or steroids, would you give them SGLT2? Because I am. So I just want to make sure that I'm on the right track.
Yeah. Yes. So that's a specific question about the role of immunosuppression, or especially in a patient with glomerular disease. We are treating patients like that who have not fully responded to glomerular disease and have the residual characteristics that were described in the studies, meaning chronic kidney disease with significant albuminuria still. So I do think it's an adjunct therapy on top of that, and I don't consider that contraindicated. And similarly, we have transplant patients that are on immunosuppression that we have started to treat. There's the guidelines for patients on transplant haven't completely followed with this. The transplant societies are moving in that direction. My transplant colleagues at University of Michigan are pretty gung ho, and even though they're not officially part of the collaborative, they have adopted a lot of the protocols that we're doing to try to increase that, because there's still plenty of patients at risk for progression of kidney disease after a transplant. So from that perspective as well. Yeah.
And in primary care, do you see a role of PCPs prescribing finerenone now or in the future?
Are you coming after my job security?
No.
No, I'm kidding.
No.
Yeah, absolutely. I mean, do you ever prescribe spironolactone?
Yes. A lot.
Yeah. So
Yeah.
this is spironolactone without the gynecomastia, So I mean, your patients are going to like it more, maybe, right? So I think that's why we wanted to present it. It is, again, so far it's been demonstrated for those higher risk patients with chronic kidney disease and albuminuria. But I think it's pretty similar to what we're used to doing with spironolactone or eplerenone, but maybe even a little bit better tolerated. So yeah.
I don't know if you treat pediatrics. I have a 8-year-old who is on the transplant list, born with one kidney and does have renal failure. From my standpoint, I don't think he has anything to lose by being placed on an oral agent such as the Farxiga or Jardiance, but the local nephrologists in the Toledo area don't see it that way. Is anyone in Ann Arbor doing any studies that he might be able to be enrolled in?
I am not a pediatric nephrologist. I don't actually know. Are the SGLT2s approved in children? They are?
Not down to age 8.
Until age 8.
Not down that low.
No, not down that low. Okay. So I don't know the answer to that.
Well, there's been some small studies that show benefit, but I just wondered if maybe if I sent him to Ann Arbor, whether he'd be able to get on a treatment plan.
Yeah, I can connect you with our pediatric nephrology colleagues for sure. We can talk later, and there's also the M line that you may be familiar with, where you can call the 800 number and get a hold of a pediatric nephrologist and ask them that question, rather than refer and then find out the answer is no. But I'd have to defer to them.
From a nephrology perspective, can you just weigh in on, like, 'cause I was some people with type 1 diabetes, CKD, major albuminuria, SGLT2s, what are your thoughts? Because what am I supposed to do with them, I guess? Like, I'd love to, if I have them controlled, they're otherwise good.
Yeah, I don't have enough experience. I know that there, and this is a question maybe I'll defer to Dr. Papasui when she comes up as well, about SGLT2s in type 1.
Actually, I can answer that question right now.
Completely defer them.
Actually, yes. We are very excited that we were able to submit a grant which got funded to do a multi-center trial for SGLT2 inhibitor in people with type 1 diabetes. And we've been working with the FDA, and we received the green light. So we got the IND, and we are starting this study as we speak. It's called Sugar and Salt. And we are going to have 2 co-primary endpoints. The main one is a kidney endpoint, which is very similar with what was done for the DAPA and EMPA. And then also a heart failure endpoint. And in my talk, I will show you why heart failure is now so relevant. And also, because you asked about type 1, we also received, we were successful to convince Bayer to do a finerenone trial in people with type 1 diabetes. And we received the FDA approval to do that as well. So 2 exciting news for people with type 1 diabetes.
Okay, any more questions before I cut people off for a third time? Okay, we're gonna have Noah Kim on our team present some work that they and our design team have been doing around a new coverage checker document, which is or coverage checker tool, which is a online version of the PDF that you've been using in the past. So I'm gonna hand it over to Noah.
Thanks, everybody. I'm really excited to be able to show off a tool that we've been working on, not only the design and informatics team, but some folks who are here in attendance that were part of our focus group for this tool. We know that coverage is your biggest barrier. That's really clear. And it's been reported that there's up to 83% error rate with traditional prescribing orders. The system is just complex, and many of you probably feel like this person kind of pushing the boulder up the mountain. And we've been here listening and working on developing the best tools to help you in this process. So it's been a journey from November 2021 up until now. I know I have at least 80 versions of the coverage guide on my computer, and we've made people wear silly hats and toss balls and do all kinds of things to get people really digging deep to let us know what the issues are and how we can address it. So the work is only just starting. And I'm really excited to be able to talk about a tool that will give you access to in about a month, the MCT2D coverage checker. And really what we want is to have this be your trusted reference tool for navigating coverage criteria for type 2 diabetes medications and CGMs. We know that there are a lot of different ways and different people who are all tackling this problem, and we're hoping that our tool captures some of that need and helps you in your day-to-day. So we've been conducting 3 focus groups so far, starting in December and January, all the way to March, to really get your input on the features that matter most and what would help you most on the day-to-day. We're really grateful to them. I don't know if Lindsay or Marissa are here, but they're from MSU. They were part of our focus group. So right now what I have is a version 1 that I can walk you through, but right now we really focus in on CGM because we know that it's endlessly complex and it takes up so much time on the phone, claims denials, different handoffs of sorts. And so we started with CGM, we started with 3 plans, but we're expanding from there. And within the next 9 months, we hope to include all SGLT2s, GLP-1s, and CGMs with an expanded list of plans. So what should you do now? Continue to use the print guide for CGM and medications, which you can find still on our website. But starting in May for CGM, you will be able to use the online coverage checker. For meds, continue to use print. And then by the end of 2024, we anticipate you being able to use the online tool to either export a PDF if you prefer, or to use it directly in your day-to-day practice. So I'll walk you quickly through what it looks like. You can select right now CGM. Ooh, I don't know how to use this. CGM or meds. Right now, CGM is kind of the product we focused on. From there, you'll be able to select a plan, and it's going to ask you some eligibility questions, and these are tailored to the plan. And we've worked really hard. We have meetings all the time with payers to get the facts straight on some of these requirements. And at the end of the slide, I'll share how you can contribute to that. But we've got a set of eligibility requirements, as well as an overview and a way to quickly get to the medical policy or formulary. You'll see that depending on the complexity of the plan, it can be 1 to 5 questions, but these answering these will be really important for determining eligibility. And either you'll have a green light, a message with steps to move forward, or if it's not eligible, you'll be able to copy and paste basically the parts of the eligibility that were not met, so that you can potentially put that into a note if there are a lot of people that get involved, and we want to help avoid duplication of checking things. From there, you'll have actionable steps. As we collect preferred DME vendors, links to the online PA process, just to reduce the number of clicks and the places you have to go to find this information, and so that everyone across the collaborative has it. And really the most exciting part that was generated by the focus group was this idea of auto-generated dot phrases. So based on the eligibility requirements and how you select your responses, it will generate suggested terms that you can copy and paste right in the note or share with your colleagues. And then at the end, it will detail the prior authorization requirements, which you can also copy and paste to send to someone else on your team, just so that everyone is on the same page about the coverage information. And lastly, we heard from folks that you want to give patients homework. This is a group project, and really patients can begin to take ownership over steps of this. And so we've got related tools that will help them kind of join in on this process. And at the end, you'll have a way to email this whole link to someone else on your team, to the patient, or to sign up to get updates. And lastly, this is my favorite feature because we've heard from care managers, from pharmacists that, oh, I got my patient a CGM because they had this exception, they had a motor coordination, or they wanted to have remote monitoring, things like that. And the report an issue box is also a place to report any idea that you have about this tool. We really know that this is just the beginning, and it will help us out a lot to know if information isn't accurate or if there's something more you'd like to see. So definitely look for this in May, and that's it.
And now we're going to hand it over to Dr. Papasui, who is our MCT2D Endocrinology Program Director, who's going to be presenting on heart failure and diabetes updates for clinical care implementation.
Thank you so much, Jackie. And hello, everybody. It's truly a pleasure to be here. And you have heard so much about the new diabetes medication, not only this evening, but also through our prior programs, as well as about continuous glucose monitoring devices. So we were thinking that it would be nice to give you additional flavor about new developments on improving quality of care for people with diabetes in general. And of course, as MCT2D, it's focusing on type 2 for people with type 2 diabetes. And thus, it is truly my pleasure to share with you some exciting data about emerging information on how prevalent heart failure is in people with diabetes. Actually, Jackie, Jake.
Other way on the clicker, the other button on the clicker.
Oh, okay. All right, so here are my disclosure. And I will just highlight the data that has led to these new recommendations that are now being adopted by the American Diabetes Association, American Heart Association, American College of Cardiology, as well as our European colleagues. So what happens is, and as a historical context, for many of us who are here in this audience, like endocrinologists, nephrologists, and primary care physicians, it is not very apparent of what and how we should identify people who may have earlier stages of heart failure. Definitely our cardiology colleagues are very versed. And therefore, in 2009, at the ADA Scientific Mission, there was a big request from all the clinicians that were there. Says, we would like to understand a little bit better, is there something that we can do to identify these patients? And should we have an active role in their diagnosis, along your question? Can I prescribe finerenone? Of course, yes. Diabetes is such a complex disease, and we have now more than 38 million. There is no way that cardiologists will be able to address this issue. This is a disease in which we need to work as a team. And therefore, the American Diabetes Association has agreed to convene a consensus to create this guide and actually to look critically at the evidence. Is there any evidence that indeed is necessary to be done outside of the cardiology practices? And the consensus was the result of more than 3 years of work in which we had the opportunity, working as a team with several cardiologists, nephrologists, primary care physicians, and endocrinologists, to sift through tens and hundreds of thousands of patients' data from known registries, including here in US, like Enhance and Framingham, but also all these European large cohort, like the Swedish and the Scottish and the 10,000 islands registries. And, I'm not going to present each of them, but by far, to our surprise, we found out that in fact, although we believe that atherosclerotic cardiovascular is the most prevalent cardiovascular complication in diabetes, in fact, heart failure is the one. In addition, we've learned that women with diabetes, both type 1 and type 2 diabetes, have higher risk and have higher rates of hospitalizations for heart failure. And that is actually true for people with type 1 diabetes that for many years were considered of having lower risks. In addition, the prognosis of these patients, once they have both diabetes and heart failure, and this is just one example, more than 100,000 people that were followed up for 5 years, mortality rates, as you can see here, are extremely high. So, in the meantime, our colleagues from American Heart and American College of Cardiology, for the same reason, they decided that they have to reclassify the stages of heart failure and try to capture a little bit better these earlier stages. We are not talking now about people who are admitted in the hospital with acute heart failure. We are talking about these people in stage A and B that are completely asymptomatic. And they have highlighted, of course, some of these phenotypic characteristics that would be more and more associated with these stages. We are also very fortunate that in the last decade, a lot of information and evidence has emerged regarding how to diagnose in a non-invasive fashion people in asymptomatic stages. And I'm talking about the emergence of these brain natriuretic peptides, which are able to identify these earlier structural changes in the heart through the stress of the myocardial wall by their increased level in the blood. And here are many of these evidence that we were able to study and see that indeed a threshold for these biomarkers has a very high sensitivity and specificity to identify those people who are at higher risk to be admitted in the hospital 6 or 12 months down the line. Again, this data is available for all of you to go over. But you are going to ask me, okay, fine, we know that you have a high biomarker, but is there any evidence that if we act on that information, we can change the course? And I'm just going to highlight here some of the evidence that we have. This is the Pontiac trial, was done in people with type 2 diabetes. About 300 people were enrolled, and they were randomized based on this 125 threshold that was shown in many other cohorts to be highly sensitive and specific to predict who is going to get a more advanced stage. And the control group was taken care of like usual, whereas the intensified group was treated as a team approach with cardiologists and optimizing some of the available tools at that time, which were mainly reliable on RAS blockade and beta blockers. And as seen here in the graph, as you can see, this intensive approach resulted in a significant reduction in hospitalization for heart failure and cardiac death in these patients. Again, a small trial, but we have now a confirmatory trial. So that's actually level A evidence, 2 large multi-center trials. This one included more than 1,300 people, again, randomly assigned to receive primary care, a screening with BNP testing, and then based on that BNP result to be randomized to a more intensive approach, including undergoing echocardiography and collaborative care with PCP specialist cardiovascular disease. And the same data here, as you can see, are clear that this approach, acting upon a biomarker screening in a highly asymptomatic patient population, resulted in significantly better outcomes. How feasible it is to screen? Well, here is an example in which a pharmacy driven team is identifying and able to actually provide this type of screening in very successful fashion. Again, just an example that these things are now feasible because we have easy to assess biomarker, and we also have the tools that can help us to implement the screening. So therefore, the consensus has published this nice algorithm in which identify people who are more likely to be in asymptomatic stage of heart failure, and then recommend screening with one of these biomarkers, and then based on that result, additional steps are recommended to be implemented, especially in a team-based approach. Again, from each of these stages, as you can see here, identifies the team members that would be critical and the steps that could be implemented. And not everybody needs to get an SGLT2 inhibitor or a GLP-1 receptor agonist. Of course, that these medications have enormous benefit in this patient population, but you would be surprised, and I'm going to share some of our experience at Michigan, that sometimes we don't realize that even simple measures like optimizing blood pressure control and optimizing ROS blockade could make, in fact, a difference in these patients and help them to have a better care. So from evidence to guidelines, it's of course a lot of work. And then from guidelines to clinical care implementations like MCT2D, aims are, it's another step, and it takes a village. It takes all of us to work together to try to do so. And I'm going to share with you in the last couple of minutes our efforts at University of Michigan, working together with Dr. Wyckoff and all our colleagues, Heidi and Lauren, and many more, in which we have leveraged this information and the guidelines, as well as the progress that is being made through health information technology services, through the EMR tools that can be used to show you how we are managing this heart failure screening. We have worked and actually been able to start this in February. So what we do actually, the EMR tools allow us to screen the entire patient population who has diabetes, and then select those phenotypes that have been shown to be more likely to be part of stage A and B, in other words, age, 50 or older, presence of hypertension, statins, obesity, as well as kidney disease, because kidney and heart, as Dr. Hunks here knows very well, are so highly correlated and increasing reciprocally their risk. In addition, we can also screen people who are not known to have a diagnosis of heart failure by ICD codes, and then see who had or not an NT-proBNP result in the last 365 days. And then automatically through the EMR, you can generate this best practice alert that immediately fires up in the encounter with the order sets for this test to be done, to actually make the life of everybody who is so busy much easier. And then once the result is available from the pathology lab, whether it's normal, and here it's the thresholds that have been shown to be associated with higher versus lower risk, then automatically the step-wise approach is being populated for clinicians to know what to do. If it's normal, they don't have to do anything. In a year, this is going to populate again when that particular patient is seen. If it's abnormal, then it will link to these various steps that we have identified to be highly effective in reducing risk for. And we will give you all these slides and all these algorithms, so no worries about that. And then again, how to avoid some medications that have been shown to increase risk for heart failure, and how to optimize the treatment and use these agents that are beneficial. So this is basically, as I said, a pretty team-based effort from sifting through the evidence, then looking at the guidelines and implementing them. And MCT2D is such an example in which the team approach can lead to better results for people with diabetes. So in summary, and I'm not going to read, the data is there. Heart failure is very prevalent. Unfortunately, a very large proportion of patients are completely asymptomatic and may have no idea that already these structural deficits are present. We do have very reliable biomarker now that we can use very easily. It's a blood test, a very easy order. And then we have now steps that can be implemented and guide therapy. It's actually, in fact, it can be an additional tool to help with coverage of these medications, because clearly that can be used as an additional diagnostic tool. Thank you very much for your attention, and happy to answer any question if you may have some. Yes.
What the percentages of patients in these high-risk populations, especially kidney disease, that actually have a BNP lower than 50? Because for me, that just seems, as a nephrologist, a BNP lower than 50, the pro-BNP less than 125, it just seems quite low. So I just wonder, like, how many of these patients don't qualify?
Don't qualify to be screened?
Right, and because the question is, if there was like in these studies, if there was an advantage in people that had a BNP higher than 50, which again, this may just be the population that I'm seeing, right, that usually have some fluid on them and like a very low BNP that we rarely see.
Yeah.
Like if there was an advantage in people that had a BNP higher than 50, would maybe everybody that, have an advantage to do this?
Yeah, so that the question was, is there a threshold? I mean, is there an advantage for a BNP at 50, for instance? And what is the evidence that if we take patients who have a BNP higher than 50, we would have an effect, right? That's the question.
Or even less than, like if you would include everybody, is there?
Oh yeah, so in fact, this is a great question. Because when we evaluated this evidence and also talking with our nephrology colleague, we're part of the consensus, the risk is probably the most defined at this threshold, but it is a continuum. So yes, even for lower level, there is an increased risk if there is chronic kidney disease. There is no question about that. However, we have to, set up some thresholds when you implement that in clinical care. In addition, with so many people with diabetes, ideally, yes, you would want to say, I want to test much more, but it also has to be a feasible approach. At University of Michigan, I think we have about, 90,000 people with type 2 diabetes that are being seen in our health system, about 10,000 people with type 1 diabetes. And then we have to, create a guide of selecting those who are the highest risk. It's the same, it's true also with NT-proBNP in the elderly. I mean, with age, it increases, but 450 has been clearly shown to have the highest inflection and the risk. But how about 350? Is this normal or it's not? And how are we going to deal with that? And my dear colleague, Dr. Wyckoff, had a question about that exactly the other day. And I can actually ask her to tell you her experience, because it was quite nice to hear, right?
No, now everyone's going to think I'm the worst doctor in the world. So I had a 70 to 73-year-old patient, slim guy, type 1 diabetes, really no complications of his diabetes. One of these people has been super on top of his diabetes for years and very excellent patient. And so I did a NT-proBNP on him because he fit the criteria. And I can't remember the number exactly, but it was like 275 or 278 or something like that. And so he's almost 75, but not quite. So what do I use for my cutoff? And I wasn't sure about it. And obviously I spoke to Radhika about it, and she was like, well, do you have his blood pressure optimized? And I thought, well, yeah, he's on an ACE inhibitor. And then I went and looked, and no, his blood pressure really hasn't been. He's been doing like 140s, 130s over 85 a lot. And then I realized, yeah, I probably should be doing a better job of it. So yeah, I'm the worst doctor in the world. There you go. I confessed.
No, it's not about that, but they may be on an ACE or an ARB, right? But they may not be optimized on the dose, for instance. So these are just examples. And yes, you are right, there is a continuum, but when you implement something in clinical care, we want to start somewhere. And we are actually collecting this data, and we will see how this quality improvement will translate in future hospitalizations in this patient population.
And I'm going to transition us for the rest of the meeting to do more learning from each other. Again, I'm Lauren Oshman. I'm the program director for MCT2D. We're going to ask for your feedback at the end of this talk. If you feel like this was the right amount of learning or too much, please let us know. But one thing we're really trying to do with our regional meetings is give you more time to learn from each other. I want you to make sure that you have sat at the table that is on your badge. So if you sat down with friends and didn't look at your badge, make sure you're sitting at the correct table. And the reason is that I've asked you to be at tables working on the same quality improvement goal over the last year. So some of you have been working on CGM improvement, some of you have been working on guideline-directed medications, and some of you have been working on low-carb dietary interventions. So make sure you're at the right table, and then I'm going to ask you to open your folder, and then you should find a handout that is a guide that we've developed, not just for this meeting, but just really to help us walk through learning about how it was to work in your physician organizations on making an improvement in one area. In the middle of your table, there should be a handout with one lucky person's name on it. You have not won the lottery, but you will be asked to facilitate a discussion at your table. So there should be someone's name. Who's Anna?
Me.
Anna, congratulations. So please pass that handout to the lucky person who's going to be your facilitator. Okay, I'm going to give you a little bit more instruction, and then I'm going to be quiet and let you start working. So everyone, please take a look at the handout, and you will see on the front there is a guide page, and it walks you through all of the different steps that we could think of. What are all of the steps someone might tackle if they are trying to improve in one of these areas? I'm going to ask you to pick one of those areas that you think you personally as a clinical champion have really made some good progress on in your clinic. And we have some stickers. We always have stickers. You don't have to use the stickers, but if you want to use the stickers, put a blue sticker on that area that you feel like you've made improvement. And then I'm going to ask you to look at that same list and pick an area that you have not started with yet, or you think is going to be really, really tough to move. And you can use a red sticker, or you can circle it. I don't care. Everyone is oriented to the stickers. Then I'm going to ask you to spend about 10 minutes working on your own. You're going to flip to the page that has that step that you really, really feel like you've been trying hard on. And I'm just going to ask you to write some answers to these questions on that step, just to really think and reflect about how this went for you. And then once you've spent a couple of minutes writing down your thoughts, you can flip to the other section, the area you feel like you haven't tried yet or will be really difficult for you. And I'd like for you to write, again, some more comments to yourself. I'd like you to spend no more than 10 minutes doing like self-thinking, self-reflection. And then the person who is the facilitator is going to allow everyone to have about 2 minutes to share what they wrote down to themselves, and then just keep a facilitated conversation going about what has been going on in your physician organization. And then we'll come back together at probably like 7:30, 7:35, and then share out as a group. Please raise your hand if you have questions about the instructions. You can't do this wrong, it's gonna be fine. And then we'll circulate if you need help. So I'll talk to you again in about 10 minutes. All right, sorry to stop all this wonderful conversation, but I do wanna share what each of you are doing around the room. And so I've got a list of different groups working on different quality improvement here. So we've got tables 2 and 3 working on CGM, 4 and 5 working on low carb, and 6, 7, 8, and 9 working on medications. Tables 6, 7, 8, and 9, would someone please be brave enough to raise their hand and report out very briefly on what you talked about amongst your group, what's going well and what the challenges have been? One very brave person. I will give you extra stickers. Thank you. Over here.
So we got off topic a little bit, but that's okay. What we identified as a positive is that identifying patients who will benefit from some of these medications has gotten much easier. Resources here, resources just out there in general. We've done a better job of reaching for these medications, the GLPs, the SGLT2s. So I think we're doing well with that. We have, of course, and I think everyone in this room has seen a lot of issues with access and coverage for these medications. Patients who would benefit greatly from these just have insurances that won't cover them, or they end up in the donut hole. We talked about that a bit. Some resources within our clinics that are probably underutilized would be care manager, who could, potentially help with looking into the coverage aspect, or who already does do that. Involving MA staff might even be someone who can, in real time look up and use the coverage website that's upcoming. That could be very helpful as well. And having like a designated subject matter expert among that team as well, just someone who, maybe takes the point for educating someone on the CGM use or something along those lines.
It's really wonderful to hear, and I think amongst our practices, one constant is that we are starting to think about diabetes in a different way, and we're starting to think about end-stage cardiometabolic disease and really identifying those at-risk patients versus one-size-fits-all. Of the other tables working on medications, can you and that, or add anything different that you found amongst what you're working on? Tables 7, 8, or 9. Anything else to add? Hearing nothing. Tables 4 and 5. Anyone willing to share what you talked about in terms of how you're doing with a low carb eating?
So we identified issues mainly in step 2, which is developing a population level process for identifying patients. It's hard to find the time in order to, within that 15-minute, 20-minute visit with the patient, to really go through and explain what low carb diets are, how they can be helpful for the patient. And when you're starting off with a patient that doesn't even know what a carb is, it's really more than you can even get into in a single appointment. So identifying patients that want to try low carb diets is certainly difficult. And then the next difficulty is, once you've convinced the patient to try it, you have limited resources for referring that patient to a dietitian. It's hard to find coverage for dietitians often with insurance.
What's going well?
What's going well is providers that have direct experience with low carb diets. So they've tried low carb diet themselves, really got to know what it's like to live with a low carb diet, identifying different programs that they tried themselves, like was it the Whole30 program, and using that intimate knowledge in order to really help patients through the process and be able to answer detail level questions.
That's really great. We had everyone try on a CGM. Maybe we need to get everybody a 30-day food subscription, and all of the collaborative members can try out different diabetes diets. Thank you so much for sharing. Our other group that was working on low carb eating, can you share maybe something else that was different or the same at your table discussion?
I think there's a big difference between our practices that have a dietitian care manager, which luckily actually 2 at my table have, and those that don't have a dietitian care manager, because the dietitian in their practices understands MCT2D and the low carb eating, whereas a practice, if they're going to refer out to a dietitian, they're not necessarily going to teach the low carb eating if they're from a hospital system or a different type of program.
Getting really high quality education can be a challenge. Would people mind raise your hand if you have a diabetes education professional embedded in your office? So not a whole lot of people have that resource. What about someone that you feel like, or a diabetes self-management resource that you feel like you can consistently refer patients to and they will go? Some folks. Raise your hand if you feel like you have no good connection to diabetes self-management resources in your practice.
Other than what we hand out.
You give them a handout. And so I think as I'm hearing more and more, we've 7 regions across the state and are getting feedback from everyone. It is really making me think, what is this team? What is the team that we have to take care of our patients with type 2 diabetes and really other chronic metabolic disorders? And what do we need to do both as MCT2D, as the state, as our practices and POs to create, define, and train that person? So 2 nights ago when we were in Livonia, someone brought up the idea of we want a low carb diet boot camp. Like, let me just send someone from my practice and give us a day of education. Can we just provide more direct education or train the trainer? As MCT2D, we can't really provide direct services to patients. So as you have ideas about what would help you, or as we not necessarily shift our focus, but focus our focus on what will help you most, please keep bringing those to us. It's really helpful. Go ahead.
I have a dietitian in my office, and it came through my PO. And so, as an individual, I have no idea how to do this, and I don't have time to do this. I mean, there's so much demands on us, on the physicians, of all the other things. And so perhaps what you need to do is get with the POs and somehow, make it worth their while to get, because they can reach into lots of practices.
Yeah, I think absolutely. That's a great idea.
And so that they can, whether it's in person or remotely, once a week, every other week, or on call as needed, because these dietitians can be available, through EMR or through the telephone or whatever. And so, and then to just the patients who may benefit, but by going to individual physicians, I wouldn't know what to do.
No, I really appreciate that comment. Thank you. Anything else to add about that?
Oh, thank you. Last spring you did the webinar that was the low carb diet based. I thought that was one of the best ones that you did.
Well, thank you.
Because it went through all the different, but also gave meal plans and stuff. I was able to go back and print out those, so that's a resource that we can give our patients.
Yeah, and I use our Jumpstart program has ended, and we're writing up the results. Jumpstart was our program. We collaborated with several practices to provide some direct meal support and education for people with food insecurity. The website's terrific. And I use all of that information. I don't spend a lot of time with patients, but I say, oh, here's something to take home. And I also encourage you to follow up with our dietitian. So I appreciate that. And again, we're trying, Rena in the back, our dietitian really wants to do what is needed by your patients, their food ways, the kind of foods that they like to eat, and provide those resources to them. I'm going to move on and ask our CGM groups. Can someone volunteer to report out from your table?
Hi there. So what we think is going really well is identifying patients who could benefit from a CGM. And in one of our clinics, we have a dot phrase that helps to fill in all of the CGM data. So once you have the CGM report, being able to translate that easily into your note is going well. And then things that we think we could benefit from additional support on are getting patients linked to our dashboards and databases, especially if they don't have the technology to utilize smartphones and apps. So for example, the Libre readers. And then also like standard procedure for the whole thing, I think we could all benefit from. And then finally, just viewing and downloading those reports for the patients that are linked, like where does the support come from for that? And how do we make that more consistent?
Thank you so much. Anyone from this table?
So we had a good discussion about one of the problems was being able to get the prior auths to go through. And so a lot of people at the table had experience using Parachute. And so I thought I should mention that because they talked, I'm sorry, Juan actually helped build that on the MCT2D website, and everybody's using it, and it works really well to get the coverage. So, and using Parachute, that's the one we talked about at the last meeting. So, and then prescribing the CGMs was the easiest. They were all able to figure out which patient needed it, but getting it covered is the problem. So that's why we talked about Parachute, and just trying to get to that point. Like, how do we get the insurance companies to cover it?
No, I think we're right on the same page in lockstep with trying to find solutions that make this easier and easier for everyone. But we live in the United States where there's no healthcare system. There is just a bunch of different insurance companies with different rules. And, it's really survival of the fittest out here with those of us trying to figure out how to get coverage. So I will say, I appreciate everything that you're doing. I really want to encourage you all to continue to give us feedback at MCT2D when we think about what makes type 2 diabetes care like good. What's good? What does excellence look like to us? What does a thriving life look like for our patients? And what needs to change in the kind of care we give patients and the kind of lives we help them live? That's really our North Star here and what we want to be focused on. And so if there are things that we're not focused on that you think we should spend more time on, we're really wanting to focus on that as well. We're going to transition and give you a little bit of a closing with what's next and what we're thinking about doing and actively doing for you in the upcoming year. Is there anyone who wanted to make a comment or share your feedback about, again, this idea of doing some dipping our toes into quality improvement at your practices over the last year as we transition our team up here to report out? Any other comments?
So we just have a few closing slides for you with just some things that are coming up and looking ahead at what we're working on developing. So we wanted to let you know about some work that we're doing with the Michigan Value Collaborative. This is like another CQI program that partners with CQIs that are doing clinical work and provides information on like the cost of care. And so we're working on two projects with them, one around exploring the economic benefits of SGLT2s and GLP-1s. So, we know that there's a lot of risk contracting and a lot of pharmacy costs around these medications. And what we're hoping to show with this work that we're doing with MVC is that we're going to be able to compare it to insulin and non-insulin, to complications, and show the effectiveness and value of prescribing these medications. The second one is on the cost efficacy of CGMs in non-insulin using patients. So like you've heard earlier, the coverage of these is often challenging in patients who aren't on insulin. So we want to be able to show that these are cost effective. So that's something that we're doing with MVC. This is just a little bit of the time frame. I'll go through this really quickly just to make sure we get out on time. But essentially, we're hoping to do the analysis for the SGLT2 and GLP-1 project by the end of September and be able to share what we find with you all, ideally at the fall regional meetings. And then we're going to be beginning the one on CGMs later in the year in Q4. And by spring of next year, we'll hopefully have some information on you for you on that. I won't go through this slide extensively, but just as a brief reminder, the VBR year closes on June 1st. So for those who haven't met their physician level learning community requirements, we have a couple calls coming up, or a couple of our events coming up before the year ends. The guiding low and very low carb diet interventions with CGM and the CGM QI focus member panel, where sites that chose CGM as their QI initiative will be sharing the changes they made and supporting and providing information to those sites who didn't choose that one but may be interested in working on that. And then we have recordings of all our previous talks as well, so you're able to watch a recording and get credit for that too. And this is just letting you know kind of who still needs to be meeting this. So reminding everyone that there's those couple months left to meet those requirements. So I'm going to briefly introduce some changes to our data hub and then hand it off to my colleague Laria, who will share some really interesting work that she's been doing on a second version of it. So as you all know, right now, our data hub includes Blue Cross Blue Shield of Michigan, Blue Care Network, and BCBSM Medicare Advantage, Blue Care Network Medicare Advantage. We're working on increasing the data sources in the data hub to be all patient, all payer, which is what our ultimate goal is. And this is just a timeline of what that's going to be looking like. So we're going to be adding all payer clinical data, which is like the BMI, the A1Cs, like those factors by the end of this year. We're going to be building an active care relationship services, which basically just lets us know like which patients should show up on your dashboard. We're going to be adding Medicaid data by Q1 of 2025 and are working on social determinants of health data, but unfortunately don't have a specific timeline for that yet. And then enhancements that we're working on to the data hub. So we do have nephrologist attribution in the data hub right now, but we don't have endocrinologist yet. Blue Cross had a model for nephrology attribution and we had to develop one for endocrinology. That's why there's been a bit of a delay there, but we're gonna have that built into the dashboards by the Q3. We're also gonna have provider delivered care management eligibility in there as well by the end of the Q4 too. And what Laria's going to talk to you about is Dashboard 2.0. So Laria and the design team has worked a lot to get people's input on the dashboards and how they use it and how it could be better, and has been working with our data vendor, the Michigan Data Collaborative, to just really improve and completely change the face of these dashboards in a way that I think will make them so much more user-friendly and easier to navigate. So I'm going to hand it over to Laria.
Thanks, Jackie. All right, so like Jackie said, I'm just going to talk briefly about some of the updates we've been making for Dashboard 2.0. This is building on our continuing effort to incorporate your feedback and your thoughts into all the tools and resources we have to try to make them as usable, as helpful as possible. So as part of this process, we asked you to participate in these 30-minute one-on-one calls around the dashboard. And if you joined us for these, we walked through the dashboard, talked about some of the different features, and asked questions about how maybe you were currently using it in your practice or how you would want to use it if it had additional features and enhancements. And we then took this data and have been using it to carefully go through and redesign each and every aspect of the dashboard, not only the back end and how our data is structured, but also the front end and how you'll be able to access it. So if you've used our patient data dashboard before, you might be familiar. This is the first thing you see when you log in. It's our attestation page. We heard that this was confusing and annoying to have to go through, and we really wanted to make this user-friendly, again, helping you get to the tools you need within it as fast as possible. So we're transitioning this to a landing page, which will look something like this. And this includes features that we heard from you were important, like very clearly saying the last time that the data was updated and what the data that was included is. Easy ways to access different aspects of the dashboard, like our patient list, so you could filter patients, patient profiles to see their overview of their type 2 diabetes, summary measures, and things like that. And then in addition, we took all of those questions that we got during those interviews and from emails and other things that you've sent us, and are creating an FAQ section right here so that if you do have questions about the data, you know where to find the answer for that as easy as possible. We decided to start this process with the most complicated page that we have in the dashboard, which is our summary measures page, which currently looks like this. And we wanted to turn it into a landing page where you could really fast and easily see some of those key measures that are important to you in your work. And so this includes things like showing you patients' controlled versus uncontrolled A1C, blood pressure, retinal exams, prescribing rates, and things like that, all on one page. Here's some examples of what those visualizations look like, and then offering ways to drill down as well to see like a detailed A1C breakdown if you're at a PO level to see how practices compare to each other and things like that. And in addition, we're working on building out some pre-populated reports so you don't have to go in and build your own comparisons in the future if you're interested in this data. So we're starting with trend reports, which will show things like prescribing rates over time that are pertinent to the collaborative as a whole, comparison reports, again, the ability to see different rankings for practices and things like that, and then also data completeness reports so you can see what kind of data is actually coming into the dashboard and how much of it we have. And so while that's being built out by our partners at the Michigan Data Collaborative, we're then transitioning to working on the patient profile page and the patient list page. Again, these may be the tools that you use most frequently now, and really making these, again, as usable for you as possible and incorporating all that feedback. So this is easy to navigate and useful for you. And this will be an ongoing process. This is so valuable to get to learn from you. And we're really excited to get to release these updates in the near future. So I just wanted to say thank you so much for coming and joining us tonight.
And to make sure to fill out that meeting evaluation, which is in your folder, you can leave that on the table or give it to a member of our team. And also to give your name badge back to a team member because we will recycle it for you. And I'll turn it back to Dr. Oshman here.
Yeah, I just want to thank our whole team who is sitting at the back of the room. If you are on our coordinating center team, please raise your hand and wave. Thank you all for all of the work. Please thank these folks for making this work for you. And then I just want to let you know that Emily Santer, our representative from Blue Cross Blue Shield of Michigan, is here. And we really just do so much appreciate the wonderful support that Blue Cross has given to us. If you have any questions about Blue Cross benefits, she's here in the back of the room and would be happy to say hi to you. Have a wonderful night and a safe drive home. Thanks.